What's 7?
You can't see it unless you're at home.
There's 15 people online.
Okay.
So, okay.
That's right.
I will start. You guys good if we get started?
Yeah.
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 Okay. All right. Hi, everybody. Welcome to this wonderful talk by Courtney Amoraal. This is a What's New in Addiction Nursing talk, and the focus today will be on injectable opioid agonist therapy, also known as iOAT, in acute care settings. And I just wanted to give you a little brief introduction to Courtney. Courtney is a third-generation white Dutch settler living in the territories of the Lekwungen-speaking peoples with their adorable dog, Hank, and I can attest to this. I was lucky enough to be able to babysit Hank for a whole weekend. In nursing school, Courtney started working at a hospice for people who use substances and had the honor of building deep relationships. Hearing them reflect on their lives, share stories about their loved ones, bearing witness to their journey in dying, and really just fell in love. Since graduating nursing school in 2013, they have provided community-based care for people who use substances through community health center work, housing-embedded primary and substance use care, specialized addiction medicine clinics, and overdose prevention services. Through this work, they developed a passion for addressing structural inequities that create barriers to care for this patient population and structural gaps that create barriers for nurses to provide excellent care. They began working in iOAT in 2019 by operationalizing the first iOAT clinic on Vancouver Island and are currently working to support iOAT implementation in Island Health acute care facilities. I'll pass it over to Courtney.
Thanks, Amanda. It's kind of funny to hear about yourself being talked about. Yeah, so this is iOAT and let's dig into it. Want to start by acknowledging Island Health operates on the stolen territories of the Nuchalneth, the Kwakawak, and Coast Salish peoples across what is colonially known as Vancouver Island. The war on drugs is rooted in racism, and Indigenous people are disproportionately impacted by the toxic drug crisis. First Nations Health Authority provides us with some data around what that looks like. And I've highlighted here for Vancouver Island. On the island, First Nation folks make up about 4.2% of our total population. But when it comes to toxic drug deaths, they make up 17.1%. And when it comes to event, it's 21.6%. Events just means that somebody experienced an overdose and paramedics were called to the scene. They didn't die, but obviously are at risk of other injuries like organ injuries, hypoxic brain injuries, and disconnection from culture and community. So still quite impactful. These are just small examples of how Indigenous people are disproportionately affected, and should really prompt us as nurses and healthcare workers to think about how am I creating safe spaces and culturally safe spaces for Indigenous patients. Something that I've been adopting in my own practice is from First Nation Health Authority resource called Supporting Opioid Use Disorder in First Nations Community. And it provides guidance for clinicians around how to provide culturally safe care for opioid use disorder. And something I really incorporated is asking my Indigenous clients, are there things about your culture or spirituality that are important for me to know and that you want incorporated in your care? Are there ways that I can help connect you to culture and your family and community to support you in your kind of journey through healing? And so something I just encourage you all to kind of reflect on and think about, what does that mean for your practice and how can you take on this work? I have no conflicts of interest to disclose. So today we're going to go through a little bit of background of why we're talking about this. We'll go through an overview of iOAT. I'm going to do a literature summary and then, a literature review and then go through a summary of the evidence from literature. We'll talk about an environmental scan and kind of current practices around iOAT in acute care. And then we'll look at barriers and possible solutions to continuing iOAT in acute care. So background, iOAT availability is limited in hospitals. It's often in hospitals that have iOAT in their community, which makes a lot of sense. But if clients travel, and they do sometimes show up to other communities, it might not be available to them. DAM hasn't always been available in hospital either until fairly recently. And there are a few hospitals that are kind of working on getting DAM into the system. If iOAT isn't available in hospital, there's no best practice right now for transitioning patients from iOAT to adequate doses of oral opioids. So it has this big potential for destabilizing patients, and that can result in them leaving against medical advice. If DAM isn't available, it could be converted to hydromorphone, but it's not really clear on what the impact to patients would be if that happens. We're in a nursing shortage and a healthcare crisis, which makes it really hard in general to provide robust care to people with opioid use disorder, especially for people that are titrating or need multiple opioid doses every day to manage their acute pain and withdrawal and cravings. This is even harder in rural and remote settings where there might be one RN covering multiple units, where you may or may not have an addiction medicine prescriber available. And then there is undoubtedly an underlying stigma at multiple layers in our healthcare system. And people who inject drugs experience even more stigma. Use of heroin as a treatment also carries certain stigma, even though withdrawal and cravings are best treated by the drug somebody is using, not necessarily any drug in that class. So we have a lot of work to do, a lot of learning to do, and that's partly why we're here today. So what is iOAT? It's an evidence-based treatment option for people with moderate to severe opioid use disorder. It's typically saved as like a higher intensity option for people who have been treatment refractory to oral OAT options like methadone or Cadian. People who were able to reach a therapeutic dose. About 15% or so of people with severe opioid use disorder are considered to be treatment refractory, although that's really shifting, and it's more and more being offered to folks as part of a spectrum of options that could potentially meet their needs. It's only used for people who are injecting opioids, and that's really because we don't want to introduce risk by having people inject who are otherwise using through smoking or other means. And in a time of pharmaceutical alternatives, I think it's important to note that iOAT is treatment, not safe supply. It's not a new kid on the block. It is a little bit for us in Canada. We've had it for several years, but it's been used as treatment in Europe for a good century. And so definitely has lots of evidence for it. For the sake of this presentation, if I'm saying iOAT, I'm kind of referring interchangeably to hydromorphone or diacetylmorphine. And if I list one of those specific medications, I'm speaking specifically to them. Yeah, so like any pharmacological intervention, iOAT works best when it's paired with non-pharmacological interventions to kind of optimize people's outcomes and success. So for those of you who aren't familiar with iOAT, I just want to give a little brief overview of what does this even look like in the community if you aren't sure. So this photo is actually pulled from a news article that was about a housing-based iOAT program that I managed here on Vancouver Island. It's no longer operating. I wanted to have this photo to try to give you a bit of a sense of what it looks like to come into an iOAT clinic. They don't all look like this, but this was ours. So in community, a patient will come into this clinic, they sit at their booth and they meet with the nurse. The nurse does this pre-dose assessment, and essentially we're trying to see that they're not overtly intoxicated, that it's safe for us to give this high-dose opioid to them. And once we complete that assessment, we'll provide the medication directly to the patient. We literally just hand it to them with injection supplies. The patient then injects it themselves, either IV, or some folks will inject intramuscularly if that's their preference. And they do that right there in that booth in the chair. If they are not successful with injecting IV, or if they prefer, the nurse can administer it IM or sub-Q for hydromorphone. Nurses in the community don't inject it as IV push, and that's because our patients are in the community. They don't have IVs in. Once the patient is done with their injection, they drop it in a Sharps container or in a Sharps container that goes to nursing, depending on the clinic. And they hang around for a post-dose observation period. iOAT kind of peaks within a few minutes and up to 15 minutes. And so we often have folks hang around for that time to observe, are they still breathing okay? Are they alert enough? And did they tolerate that dose? And if so, then they're free to kind of leave afterwards. For some folks who are really stable and on a maintenance dose, that post-dose observation might be shortened to 5 minutes. Or for some really stable patients, it's actually waived and they're able to leave. Increasingly over the last couple of years, starting in COVID, some patients started having prescribed carry, so able to get one witness dose in the clinic and then leave with their other dose or 2 doses for the rest of the day for them to use in the community unsupervised. Often these clinics are also staffed with peers who are just like essential workers when it comes to substance use care, help create that welcoming space, support patients through their injections, and monitor and engage with them afterwards. So there's lots of literature about iOAT. I want to highlight kind of 3 key ones. This was a Cochrane review from 2011. It included 8 randomized clinical trials, mostly from across Europe, but one of those RCTs was in Canada. And it has a total of over 3,000 patients. And what they're looking at is comparing diacetylmorphine or DAM to any other treatment, which for the most part was methadone. Primary outcomes that they were measuring were retention in treatment, substance use, death, and medical adverse events. Secondary outcomes were crime, incarceration, and social functioning. So things like integration into work, relationships with their family. Ultimately, they concluded that DAM was more effective than methadone in a number of these areas. Understandably, it does have a higher rate of adverse events and serious adverse events than methadone. And so in these studies was recommended for supervised clinical settings. The next 2 are Canadian studies. So this was the Canadian study that was included in that Cochrane review, and it's the North American Opioid Medication Initiative, or NAOMI. This happened from March 2005 to 2009, and it was the first clinical trial in Canada. Patients in this trial were randomly assigned to either methadone or DAM. It had to be open label. People know if they're getting a liquid orally or an injectable opioid. They had about 25 people that were not included in these results, but that were randomly assigned to injectable hydromorphone, which is really interesting. They did this for validation. So the patient is self-reporting their substance use, but it's a bit difficult to differentiate on a urine drug screen between illicit heroin and pharmaceutical heroin. So they had 25 people randomly assigned, blinded to the clinicians and to the patients for hydromorphone so that they could validate. And what they found is 100% of the reports of not using at all were confirmed on urine drug testing. So really helped to validate that. Primary outcomes for this one were measured at 12 months and included retention, reduction, or elimination of substance use and illegal activities. People were really worried that providing injectable heroin to people would worsen addiction or enable people. And research has really shown us that that's not true. In fact, it worked better than methadone at meeting a number of those outcomes. Through the fellowship, I really had the pleasure of going to the iOAT clinic where these studies happened, and I met a number of the patients who were in this original study. And it was really incredible. They're doing so well. Many of them are very healthy, engaging regularly in their health care, had started working again, were reconnected with their family and their children. We're just having such great health outcomes. Many had de-intensified how they were using. So instead of injecting IV multiple times a day, had transitioned to intramuscularly. And so really incredible to see and hear from them firsthand what the impact of this work has been. So in that NAOMI study, patients and researchers didn't know if they were on DAM or hydromorphine. They couldn't tell even after the medication was administered. And this brought on this really kind of brilliant thought that was like, we should question whether injectable hydromorphone could be used instead of diacetyl morphine. And that's really because DAM wasn't readily available in the community. It wasn't manufactured in Canada at that time. And so it's really hard to access. And so they thought, if we give people injectable hydromorphone, would they experience similar benefits? And so this was the study to assess longer-term opioid medication effectiveness, or SALAMINE. And so it's an inferiority trial. Patients were randomly assigned to receive injectable diacetyl morphine or hydromorphone. In the hydromorphone group, 48% thought they were getting DAM or they weren't sure. In the DAM group, 64% thought they were receiving hydromorphone or they weren't sure. So people really didn't know, and neither did the clinicians that were administering the medications. The primary outcomes included use of unregulated heroin or other opioids, urine drug screenings, and then secondary outcomes were treatment adherence, physical and mental health, crime, and cocaine use specifically. Really what it showed was similar treatment retention to previous studies. Similar outcomes for hydromorphone and DAM, which really demonstrated that iOAT with hydromorphone would be similarly safe and effective as diacetyl morphine. In terms of adverse events in this study, they had 5 serious adverse events for hydromorphone, mostly respiratory depression, and 24 for DAM. Seizures and overdose accounted for most of the adverse events, and all 11 of the seizures that happened in this study occurred in the DAM patients. And so one of the I guess kind of results of this was to suggest that DAM potentially has more adverse effects than hydromorphone. So there's some key operational differences from the community iOAT program I described to how we would do this in acute care. And so I did a literature review of acute care-based iOAT, and there is not nearly as much research, definitely not clinical trials in this setting, but I found a number of case reports that I want to go through with you, and I think there's some really good learnings and potentials for more research. So this case report was from 2016. It's a 51-year-old man with polysubstance use. He'd started using heroin when he was 13, had multiple attempts at OAT. He was actually in the SALAMINE iOAT trial, which is really interesting. And at that time was no longer using illicit heroin. He was completely abstinent, and this was because of iOAT that he was on. He presented to a Vancouver emergency room and had a large bowel obstruction, so was booked for emergency surgery. And they were attempting to titrate up his post-op pain with some oral and IV morphine, but his pain was 10 out of 10. He was agitated and he was not able to collaborate in care. And so the addiction medicine team at this hospital called the physician involved in the SALAMINE study to talk about the kind of care that he was receiving there, and was able to determine he was getting about 720 milligrams of DAM equivalents. All of the medication doses in the SALAMINE study were in DAM equivalents, so that nobody knew which medication it was. There's no clear guideline for how to convert that to methadone, but they did their best, and they estimated it would require 120 milligrams of methadone. The thing is that when we're converting, we tend to be a little bit conservative in switching between opioids, and especially with methadone. If they put that all into one dose, we get a really big peak. And so what they did is they split it into 3 doses of 40 milligrams, and that's to reduce the peak and risk of respiratory depression and just provide some smaller peaks for him to ensure that he's able to tolerate it. And then they also did this hydromorphone. There might have been other reasons why they split it in 3 as well. Over the 8 days, he used about on average 20 to 50 milligrams of hydromorphone daily in addition to his methadone, and his pain was well controlled. His withdrawal was well controlled. He was able to participate in care. He became much more pleasant, and ultimately he was able to be discharged home and continued in the SALAMINE trial. What's important for me about this case report is that it's a good example of why we need to be able to continue iOAT in hospital. This was a really difficult experience for him, especially when trying to manage his post-op pain. And it was extra challenging because of the blinded nature of being in this iOAT study at the time. Converting opioids, or the research around converting between opioids is based on chronic cancer pain for opioid naive patients. And so when we're looking at converting opioids for this patient population who have chronic opioid use, often really high tolerance, often when we convert, we end up underdosing people. And this means they have undermanaged pain, withdrawal, and cravings, increases their risk of leaving AMA or having trouble participating in care with us, needing to use their own supply of substances to manage that. It makes it really tricky. And so one of the recommendations from the author in this study was to do some research around how to do better opioid conversions for this patient population. This was a case report from 2020. A 47-year-old man with severe opioid use disorder, a 30-year history of injecting and currently using 2 grams of fentanyl IV daily, had presented to a Vancouver hospital with a 2-day history of right lower quadrant pain. He had acute appendicitis. They tried to manage his opioid use disorder with oral morphine and IV morphine, and ultimately this was not sufficient, and he left AMA to treat his pain. Came back later that night because he was a sick puppy, was readmitted, IV antibiotics were started, and they started some hydromorphone 10 to 20 milligrams IV every hour, which was given about every 80 minutes for him, and he was still in withdrawal, still in pain. So what the addiction medicine team did is they connected with a community iOAT program and were able to secure a spot for him and decided to initiate iOAT in hospital for him. There's no guidelines for initiating iOAT in hospital. There is for the community. So what they did is they started with 20 milligrams every 3 hours, plus 10 to 30 milligram IV PRNs, and a little dose of slow release oral morphine to provide that long acting backbone, and they increased that daily. After a week, he was at hydromorphone 160 milligrams IV TID, plus 20 to 30 milligrams every hour, and his slow release oral morphine of 600 milligrams. So in this case report, they described the nursing monitoring, which is really important because it really kind of has set the stage for what this looks like for us now in acute care. Nursing monitoring was more intensive for the first 3 doses of any dose, for 5, 10, and 15 minutes post-dose. And then decrease that level of monitoring for subsequent doses because the patient has essentially demonstrated tolerance if they've been breathing okay and are alert during those more intensive monitoring. This was really successful for the patient. He completed his antibiotics. He got the medical care he needed. He eliminated use of unregulated substances during his time in hospital and transitioned to a community iOAT program. He was still in that program 6 months later when they followed up with him. The authors noted in this one that people who use substances require baseline opioids to manage kind of their baseline requirements, but then in the context of acute illness also need additional opioids and non-opioid pain management like ketamine to help manage their acute pain and withdrawal. And that long-acting and short-acting combinations are often more successful. Okay, and then this is a really interesting case report from 2021. This is actually from Toronto and was inpatient iOAT for a pregnant patient. So this woman had polysubstance use, using a gram of fentanyl a day, on a bit of methadone through her primary care provider. She was unable to stabilize as an outpatient on her oral OAT. So they tried a few times to do short-term admissions in hospital to try to stabilize her, weren't successful. She was having multiple overdoses. She was very unwell. And so they got a team together of a number of specialists and ultimately came up with this plan with the patient that she was agreeable to. And so they decided to admit her in hospital for the remainder of her pregnancy, initiate iOAT, knowing they couldn't continue it in the hospital. There was no iOAT in the community in Toronto at that time, but their goal was really to prevent maternal mortality, to retain her in care, to prevent opioid withdrawal, which leads to premature delivery. And she agreed to it. So at 32 weeks gestation, they admitted her to hospital. They up titrated her OAT and iOAT. They started at 10 milligrams and got her up to 90 milligrams IM or IV BID. Because this hospital had no infrastructure for iOAT because it wasn't available in their community, a physician ended up being the one to administer it. Sometimes they supervised her self-administering it in hospital. Sometimes the physician administered as IV push. And did that post-dose observation. And that's really because they didn't have the infrastructure to support nursing to do it. She had one incident of oversedation, and this was after she returned from a pass from the community. She had been using substances at that time. They held the dose. They monitored her closely. She didn't require any naloxone. They did decrease her dose a little bit of her iOAT, but otherwise continued it, and she was successful. She remained in hospital. She had no further substance use while she was in hospital, according to patient report and UDSs. She did deliver her baby, and it was adopted to a family that she knew personally and had chosen it, and that had been her goal throughout her pregnancy. Something to highlight here, one is that infrastructure for continuing iOAT in hospital is so important to make sure we can support people. Two is that oversedation is not in and of itself a reason to stop or discontinue treatment for people who use substances. We always want to consider this bigger picture. Have unregulated substances been part of this picture? Are there medical reasons for oversedation like sepsis or other kinds of things? Yeah, okay. And then lastly, we have this case series. So this was just published in 2022. It's a retrospective review of 4 patients that were initiated on iOAT during admission. It's a convenient sample. There are limitations for this for sure, but still really good, important learnings. The authors really noted that hospitalization is an extra challenging time for people with severe opioid use disorder. And we know this from our practice. Often their pain is undermanaged, they're in withdrawal, more likely to leave AMA, and this increases their risk of morbidity and mortality. It also increases their rates of returning to hospital within 30 days. So it's a high cost for our system. The outcomes that they were measuring in this case series were to show dose titration schedules for hydromorphone in hospital, reports of leaving against medical advice, and continuation of iOAT in community post-discharge. All of these patients had tried OAT before. None of them had been on iOAT. They started somewhere between 4 and 20 milligrams IV Q2H and quickly titrated to a suitable dose when tolerance was demonstrated. And this was really patient-led titration based on their self-reported cravings, use, withdrawal. Despite all of them having a significant history for leaving AMA, all 4 of these clients stayed until medical discharge, and they all had pretty serious reasons for admission. They all stayed until after iOAT started initiation. 2 out of 4 of them stopped their unregulated substance use altogether. None of them had an adverse event while they were on iOAT in hospital. All of them were able to be connected to an outpatient iOAT clinic, which was really great. And they all continued that treatment on discharge. 2 out of 4 of them actually restarted oral OAT, and only 1 of those patients was readmitted within 30 days post-discharge. So in all of these case series, nurses were administering the hydromorphone as IV push, and then doing that higher intensity monitoring of 5, 10, and 15 minutes. In this case, they were doing it for the first 48 hours and then decreasing the level of monitoring. What this really shows us is that iOAT titration in acute care settings is feasible. It might help people to reduce their substance use. It might reduce the rates of leaving hospital AMA, although this is obviously a really small sample size, so it's not technically generalizable, but it leaves us with a lot of hope and really kind of reflects what people who use substances tell us in terms of how to retain them in care. The authors recommended having a plan to discharge to the community iOAT, but even if that's not available, that it could be considered for folks to help them be successful with getting the medical care they need, even if you don't have iOAT to send them to afterwards. And that would always be really a collaborative care plan with the patient about what that looks like, and still wanting to connect them to really good care afterwards. Just to show you kind of two examples of the titration schedules. This was one, it was for a 39-year-old female. She had a severe neck abscess. She was using 1 gram of fentanyl IV a day, as well as some crystal meth. She had left AMA 2 times in the past 3 months before this admission. She started iOAT and reported significant pain and withdrawal relief. She had no substance use during her admission, and she completed her antibiotics. 3 weeks post-discharge, she was in that community iOAT program and was using very minimally, just 100 milligrams every other day, which is quite small. By comparison, this was a 52-year-old man with spinal osteomyelitis. He had left AMA 1 time in the past 3 months and was using about half a gram a day of IV fentanyl. Started iOAT, completed antibiotics, no reported use in hospital, and discharged into a community iOAT program. You can see that their dosing is actually quite different and not necessarily directly related to their reported use. So the way we dose iOAT really does need to be patient specific and kind of patient-led, and as well as assessing their tolerance as we kind of go through this process. So a summary of evidence: hydromorphone and DAM are safe, effective, and cost saving, and more than methadone. Supervised clinical settings for people who have been treatment refractory is what's recommended, although current practice is kind of leaning towards carries in less witness doses for some very stable patients. Even though there's limited research in acute care settings, hospital continuation of iOAT probably does help to retain people in care, support completion of medical treatment, and should really involve some strong discharge planning for folks. In terms of adverse events, as you would expect, overdoses, seizures, and infections are going to be the most common, and they are more common in DAM, in particular for seizures. In the Naomi study, 11 seizures happened in 4 of their DAM participants. It's not a contraindication to use DAM if somebody has seizures. We just want to be more cautious if they do have risk factors for a lowered seizure threshold. The overall rate of respiratory depression from iOAT is 1 in 6,000 injections, which is quite low. It's a very safe intervention. And then in terms of infections, because sterile equipment is used, it's eliminating the risk of bloodborne illnesses like HIV or Hep C transmission. But both Canadian trials found that there was also a decrease in soft tissue and skin infections in iOAT patients. So for non-medical injections, when people are using unregulated substances, the literature shows that the prevalence of cellulitis or abscesses is about 7 to 37%, depending on lots of things. For hydromorphone injections in iOAT, it was 2.4%, and for DAM, it was 4.8%. It's a bit more irritating. And so still improved outcomes compared to unregulated substance use. Outcomes for iOAT, we've talked a lot about this, really good. Compared to methadone, the DAM group had greater improvements in physical and mental health, economic status, employment, relationships. For retention and care, folks on methadone was about 54%. For hydromorphone, it was more than 80%, and for DAM, it was 87.8%. Really good retention rates. Reduction in illicit drug use or illegal activity for methadone was 47.7%, and for DAM, 67%. More research is needed in terms of acute care IO initiation and continuation, but definitely is supported in the case reports that have happened so far in improving outcomes for patients. So let's get into the environmental scan. So since 2018, IOAT programs have emerged in BC, Alberta, Ontario, and New Brunswick, and most of them are embedded in some kind of existing service or clinic. Right now, as of last year, we have 374 clients on IOAT, and it's about 50-50, whether on DAM or hydromorphone. There's more than 200 people on the wait list, but just important to note that it's not necessarily reflective of how many people actually want IO. A lot of wait lists get closed, and it's because people get on treatment and often stay in it for quite a long time. It's open-ended, and many people actually have to wait for years before they get onto IO, if at all. Over 1,600 people in Canada have been started on IO since 2018. So what's the big difference between community versus acute care settings in BC? There are definitely some key differences. In the community, we often have one nurse to several patients at a time, and the clinic itself might see a few dozen, maybe 100 IOAT patients throughout the day, but never necessarily at the same time. Those nurses are trained in IOAT provision, regularly using those skills, and employ RNs, but also LPNs and RPNs that are kind of working to full scope in those clinics. By contrast, in acute care, of course, we have one nurse to 5 to 8 patients, depending on staffing that day, the unit that you're on. Higher acuity units definitely have better staffing ratios. Nurses in acute care often have little or no training and may actually feel like they have limited experience in substance use care itself. And then in acute care, in most health authorities, only RNs can give as IV push. In some places, RPNs are able to, but often organizations limit LPN and RPN scope. And part of that is just lack of experience and use of the skill of using an IV. What that means is that we have less people that can provide this intervention. In the community, patients are self-administering IV or IM. The nurse can support with an IM or sub-Q injection for hydromorphone, but not IV. Whereas in hospital, patients aren't able to self-inject for a number of reasons, including organizational policy. And so the nurse is usually the one administering it as IV push, or might be doing it IM or sub-Q. In the community, most clients are continuously supervised for 15 minutes, whether directly by a nurse or directly by a peer or other kind of trained worker who alerts the nurse if there is any kind of sign of an adverse event. Whereas in acute care, nurses can't sit at the patient's bedside for 15 minutes and watch them most of the time. And so we're doing intermittent reassessments and coming back those 5 minutes or coming back between 15 to 30 minutes later. Patient focus in community is focused on substance use care usually, plus or minus wraparound supports like primary care. Whereas when you're in a hospital, you're caring for a broad range of admitting and co-occurring diagnoses, not just substance use care. When it comes to prescriber training in the community, the Provincial Opioid Agonist Treatment Support Program is required, and there is an IOAT-specific module, and there is IOAT-specific training, like preceptorships available for folks that are really interested in IOAT. But within acute care, the College of Physicians and Surgeons of BC leaves that to the health authority to decide. So most of the health authorities require someone with addiction medicine expertise to be the one to prescribe IOAT. But this really creates problems in especially rural and remote areas where you might not have an addiction medicine prescriber, or weekends or times where addiction medicine isn't available. And so lots of health authorities will allow any of their hospital prescribers to prescribe this if they've had a direct consultation with an addiction medicine specialist, so never on their own. Best practice guidance is available for community IO, and the national guidance does have a little bit about acute care, but it's not really specific or as robust for acute care guidance as we would like. And then ability to manage adverse events is truly capable in both settings, but of course, hospital has the ability to provide a higher level of care. We have code teams, we have RTs, we have lots of other kind of supports. We can intubate if needed. And so more robust care here, but absolutely we have adequate support in the community to do this. So key assessments. PAUSE is a sedation scale that's used in all of the health authorities for IO in acute care and the community, and it is best practice. We always do this with respiratory assessment. Ability to stay awake is a key indicator of sedation, and sedation is an early predictor of impending respiratory depression when it comes to opioid administration. It's not explicit in most of the order sets for in the different health authorities, but we're also assessing for signs of acute intoxication. So dyskinesia, slurred speech, agitation, smelling of alcohol. If somebody is acutely intoxicated or they tell you I've just used substances, generally we're going to hold the dose because we don't want to contribute to toxicity. And once that person is less intoxicated, alert and breathing adequately, then we can continue their treatment for them. Most health authorities advise to just notify a physician if a dose has been held for some reason. And then nurse would always use clinical judgment to decide, do I need a blood pressure and heart rate? Because opioids absolutely can affect those. Pulse oximetry might be included, but I always say it's not actually a great indicator of respiratory assessment. It doesn't actually replace our true respiratory assessment and physical assessment of that person. So if you've never seen a Pacero score or scale before, this is just a really simplified version. The literature supports its use because it's a nursing-friendly sedation scale. It links our assessment with actions. So nursing actions might be holding the dose, providing respiratory support or oxygen, assessing for other causes of sedation, notifying the prescriber. Higher acuity settings like ICU sometimes use different sedation scales like the Richmond Agitation Sedation Scale. But it's important to note that that's not necessarily recommended for iOAT. RAS is used to assess, ventilated patients and for intentional sedation, not for iOAT or pain management even really. Selecting which scale to use depends on the goal of treatment, and for iOAT PAUSE is what's going to be recommended. Luckily, it's pretty user-friendly. So in my environmental scan in BC, there's a lot of similarities to what the different health authorities have set up. This includes Interior Health, Fraser Health, Vancouver Coastal Health. Northern Health doesn't have a community iOAT program right now, despite really trying. And Island Health, we previously had iOAT in the community and do again now. And so we're doing some work to update our internal processes and kind of re-implement iOAT within acute care. So these 4 health authorities have infrastructure already to support iOAT with hydromorphone, and then Fraser Health and Island Health right now are working on the infrastructure for DAM. Clinical order sets are used by all the health authorities, and this is great. It's recommended because they really help to reduce risk to the patient, improve safety, and help support nursing practice. There's no standard training. A lot of the support that happens is elbow support for nurses. Some sites that more often care for this patient population might include iOAT within their orientation. But otherwise, training tends to be just how we address any new medication as nurses. We look up the IV monograph, we talk to our pharmacist, we talk to our CNE or the prescriber and find out what do I need to know in order to give this medication safely. Because iOAT is so unavailable in the community, 370 some odd people in all of Canada have this treatment. It doesn't make sense to train every single nurse everywhere because by the time you actually encounter an iOAT patient, you probably haven't done that education recently. You might never end up using that skill. It doesn't make sense to mass train. And so this is kind of the approach that many health authorities take. So I want to highlight a little bit of differences in the post-dose IV monitoring. for the 4 health authorities that are doing iOAT and acute care right now. In line kind of with those case reports, you'll see for the first few doses, all health authorities are doing that higher intensity monitoring for the first few doses. This helps us know that the patient does have tolerance to their dose in the context of their acute illness, which might increase their risk for overdose. And then once this happens, subsequent doses tend to have decreased monitoring. And you can see that that varies a little bit depending on the health authority. Right now in Island Health, we're working on changing to kind of align with the idea of de-intensified monitoring post-dose. If that patient then has another dose increase, how that's approached is a little bit different in different health authorities. So you might go back to higher intensity, you might continue with subsequent dosing, but truly nursing is always needing to use clinical judgment to decide whether to increase this monitoring or not. This is the minimum requirement. We definitely want to increase that if someone is frequently overly sedated or becoming medically unstable, or if we're just really not sure. The truth is nurses don't have capacity to do this higher intensity monitoring for every dose 3 times a day, every day of the patient's admission. And so this is really reflective of the safety of IO in terms of there being 1 adverse event of respiratory depression and 6,000 injections, and recognizes nurses' capacity to monitor. So barriers and possible solutions. Nursing capacity is definitely a big barrier, especially in this healthcare crisis. Interestingly, feedback from 2 of the health authorities was that often the higher intensity monitoring isn't necessary, and that especially experienced nurses sometimes do employ clinical judgment. They do provide that level of monitoring when it's indicated, when somebody is at higher risk of toxicity, but maybe less so for really stable patients. Ultimately, we need protocols in acute care that support nurses to make those decisions. Remembering that that rate of adverse event is quite low compared to unregulated substance use. Managing unregulated substance use is going to take up way more of our time than doing IO. And so optimizing medication management in acute care is really important, including for IO, and might actually overall reduce our workload, although that's going to be really situation specific. We really have to reframe IO as a priority, and I don't mean nurses for sure, but also organizationally and structurally. Yes, it's high intensity, but it's a highly effective treatment for people that are the hardest to treat, who have not been successful with other treatments. There's other health conditions we care for all the time, like sepsis, that also have a higher intensity or increased monitoring requirements. And we have to think about substance use treatment in the same way and be resourced appropriately to do that. Placements in high acuity units shouldn't be necessary for a stable patient on maintenance doses. It might be indicated for somebody who is at really high risk or is titrating really quickly or medically unstable. Scope optimization in hospital would make a really big difference. Having LPNs and RPNs that can administer IV push would make a difference. Being able to train peers or addiction recovery workers, healthcare workers, pharmacists could be trained to support post-dose monitoring and connect with the nurse if there's an adverse event, just like we do in the community. Providence Health found that it took an average of 12 minutes for the nurse to do their pre-dose assessment, draw up the medication from the vial, go through all of the steps of iodine administration, 12 minutes. And so things like having pre-drawn syringes might contribute to medication waste, but it's probably going to help nurses to decrease the amount of time that they have to spend just to give 1 dose of iodine. Discomfort with high-dose IV opioids totally makes sense. Many acute care nurses aren't used to giving these kinds of doses, and we don't want to kill our patients. That's totally fair. This is truly an education need. Many nurses aren't going to have the opportunity to gain a lot of experience in IO provision because there's so few patients that are on this treatment. The approach that we've been taking in Island Health is to do these education events, and we've done 7 of them now all across the region for nurses and nursing leaders. And really it's on broader principles of high dose opioid administration for this patient population. So in this education, we teach a lot on the current drug supply in terms of potency and compare it to hydromorphone and morphine. And I just find that is so reassuring for nurses when they see what people are actually exposed to and really shows that high tolerance that people might have. That being said, those dose equivalents aren't an exact science. And so we talk a lot about how to assess if that high dose is the right dose for that patient. How do I know that they've actually tolerated it? How do I do a really good pre and post dose assessment so that you feel reassured that I'm not going to cause harm to this patient? That can be really impactful. Practice resources. We have a 20-page procedure that we're writing, and I expect no nurses to ever read it ever. Quick reference guides, IV monographs, those kind of easy to use bedside resources are so important for nurses. Having access to supports like the BCCSU 24/7 line and making sure nurses are aware of that makes a big difference, especially for nurses working overnight who don't have their CNE or a pharmacist to call. And can still get that addiction medicine specialty support. And then formal education really could be geared towards nursing leaders and then targeted areas that are more likely to care for people who use substances. And then integration of specialty trained nurses who have that addiction medicine expertise that can provide more elbow support and consultations to our acute care colleagues to really provide really good substance use care. IO programming is even more difficult in our rural and remote areas, and urban centers do often get prioritized for resources, and that includes iOAT and DAM specifically. They're more vulnerable to supply chain issues and staffing shortages. Some programs in remote areas have low census with their hydromorphone, and they expect if they could offer DAM that there would be more uptake. Ministry requirements around DAM and outpatient pharmacies is really kind of a big barrier to expanding DAM in the community. And so, working with, this is an even bigger problem in rural areas because you might have one pharmacy to work with who may or may not be able to meet that requirement. So a possible solution is working with inpatient pharmacies. So having them dispense IO to the community program. This would also help the hospital itself to be more familiar with IO and more easily provide that continuation in hospital. Either way, programs work really closely together to support nurses who might be uncomfortable with high doses, to support discharge planning for patients. Acute care, IO initiation. So as discussed, people with severe opioid use disorder have a really difficult time in hospital. Treatment for opioid use disorder that is initiated in hospital is associated with a decrease in use of unregulated opioids and increased engagement in community care upon discharge. So this is why it's so important for us to consider IOD initiation in acute care. But it does require that more frequent dosing and higher monitoring. So how do we do it? Scope expansion is definitely something to explore for nursing colleagues, peers, interdisciplinary colleagues. Adequate resourcing is needed, including expansion of addiction medicine teams, which are shown to improve outcomes for folks. Having cohort units where nurses can have targeted training and resources to provide really good care could make a really big difference. Provincial best practice guidelines, having standardization of order sets also can be helpful for this. A really great paper was published this year looking at structural stigma within inpatient care for people who inject drugs and implications for harm reductions. And really what it shows us is that individuals with substance use disorder have high levels of stigma in healthcare. It's worse for people who inject drugs and worse for people who experience intersections with racism. Stigma leads to poor care outcomes. It's really well documented. It can manifest as social or interpersonal. So when stereotypes for specific social groups are endorsed, believing people who use substances are inherently violent, demanding, drug seeking, or non-compliant. It's worsened by structural stigma when our policy and procedure restricts the rights of people who use drugs. This connects to self-internalized stigma. How can anyone participate in care when they're repeatedly hearing that they're not worth it, that they shouldn't be here? Examples of structural stigma can include the lack of knowledge, skills, and training for our healthcare workers to provide good care, poor distribution of resources, withholding of services, undertreatment, policies and procedures that contribute to inequitable care, not involving patients in care decisions, discharging them prematurely. Ultimately, we as nurses and healthcare workers need appropriate training and patient care. We need resources to be able to provide excellent care for everyone, every time. What can we do as nurses? Advocacy for optimized pain withdrawal control. If you work in Island Health, I have a great SBAR communication tool to help advocate for opioid prescriptions for clients. Reporting gaps. I always tell nurses, have a little save a Word document with your recommendations. If you're filling out a PSLS report, ask for more resources, ask for peers, ask for training. Just make that a part of your practice. Report these gaps, know where to get help, work with interdisciplinary teams, doing really good pre-dose assessments, drawing on those broader opioid principles, doing our due diligence around ensuring the last dose was tolerated can be really helpful. Combining tasks when able, so giving out and then doing wound care with someone, especially in the beginning to help you build up that confidence with, yes, they do tolerate this. I'm here and I know that they're okay. Professional development, if you're a VHOD nurse, you can be paid to take some addiction medicine courses, and you're welcome to reach out to me about that. Joining harm reduction working groups, talking to your leadership about your workload, especially if you're trying to titrate a patient, and just recognizing substance use care is important, necessary, and life-saving. Lots of opportunities for further research and QI, and I won't belabor this because I know we're really short on time now. But I'm particularly interested to know what are patients' experiences when they come into hospital and receive iOAT. What's it like to not be able to do your own injection, to have the nurse inject it for you? Definitely having safe and feasible post-dose monitoring and understand how we can do this really safely in a way that appreciates nursing workload would be really helpful. Have some resources here for you. Don't forget about the BCCSU addiction medicine line. And I have a million resources with some really cool papers and information if you're interested. All right, that's it. Yeah, thank you. Thanks. Yeah, Marianne.
Do most patients that are coming in and excuse my ignorance, I haven't worked along with this client, but patients that are coming into hospital with their addictions, are they coming in because they are 35 weeks pregnant and they've got appendicitis, and are they coming in with something else, and then we're supporting their drug habit, if I can say that without being criticized, while they're in the hospital for that other medical treatment that they're coming in for? Or are people coming in for treatment, and you use that term often in this treatment? Is treatment treating the person so that they will soon be not taking drugs anymore, or is treatment supporting what they are already taking? I don't understand that.
Totally. That's great. I feel you, and I think lots of people have confusion about what is the definition of treatment, and I think that really varies even among the addiction medicine community. I think broadly treatment is considered to be interventions that help stabilize a person in multiple ways, whether that means they're abstinent or not. Treatment in a lot of the literature around that I was looking at with IO was looking at reduction or elimination of substance use, and those broader indicators of success like physical health, mental health, returning to social functioning, things like that. aside from the situation of the pregnant woman, the case study that was admitted in Toronto, yes, we're talking about people who are coming to hospital for all sorts of reasons, not for initiation of IOAT typically. It tends to be that there are other things going on.
Right.
And while they're here for their broken leg or their stroke or their cellulitis
Yeah.
or their endocarditis,
Yeah.
we also do need to manage their substance use care. And so, yeah, that's the context. Great questions.
Yeah, but when they come in for that endocarditis, we're not saying, oh, by the way, you have an addiction, we're going to try and, wean you off of that. Or are we saying, you're in for your endocarditis, we're gonna look after that, and then we're gonna support your, what you're taking?
Yeah.
Are we talking, having a conversation at any time saying,
Yeah.
are you ready to kick this habit?
Totally, yeah, we should be doing that for all patients who are admitted with substance use for sure. It's both. So it's always going to be patient specific. Some people are going to come in and already really stable on their medications and want to continue that and feel comfortable, and that's great. We're constantly working with patients to see where's your pain at, how is your withdrawal. If they're using in the community and they come into hospital, they don't magically stop using. They're going to go into withdrawal. And so are there things we can prescribe to help you be comfortable? And a lot of these case reports, they tried other things first, like oral morphine, IV morphine, not formally initiating IOAT. They tried a lot of other pain management strategies to try to manage that, and it wasn't successful. People leave hospital, they end up not getting medical care and can die in the community or have long-term consequences. And so the literature really supports doing both, and it's a big basis for why we see expansion of addiction medicine as a specialty consult service in hospital. When we can do both, it's better for patients in terms of their medical care and their substance use care. It's better for nurses and clinicians in being able to manage the needs of people who use substances and help them be more comfortable. If you think about that guy that had the large bowel obstruction, his pain wasn't managed, and he could not participate in care. When they were able to get appropriate medication management for him, it went a lot smoother for everybody. And I hear that from lots of nurses I do education with. When they do it, it works really well for people. Whether that's IOAT specifically or other medication management, we got to explore what's going to work for that person, try and meet them where they're at.
How often do you throw ketamine in there?
That's like such a great question. I have very limited experience with ketamine. I was only actually first started working with it a few weeks ago with an amazing prescriber with the Nanaimo Addiction Medicine Consult Service. It's typically used for acute pain management. Something like 10 milligrams TID can be super effective for managing pain. It's not addictive. It has different effects depending on the dose that you use. And the doses we use it at for pain management aren't the dissociative effects or other things. And so it's really, really helpful. It doesn't contribute to sedation or respiratory depression if you're also doing opioids. I can't speak to the nuances of when it would be contraindicated for someone, but I've seen it just be so successful, especially for perioperative patients and other people with really acute pain in conjunction with opioid therapies to help manage opioid withdrawal and cravings. Yeah.
Yeah, thank you. Like, are you sending it out?
Yeah.
So we have the numbers and everything.
For sure, absolutely. It's also the BCCSU. This is part of the What's New in Addiction Medicine series, and they'll have that posted on their website and on YouTube as well. But we can share the slides with you for sure. Were there any questions online? Oh, great. Okay.
Just ask, so you're talking more sort of injectable opioids, and we see probably more often in the acute care setting, the Suboxone, and the methadone. So do you see people started initially on IOAT and then transition over?
Sometimes.
Or is it more like, are you saying like injectable potentially is better than?
That's such a great question. I wouldn't say it's better. It's part of a spectrum of care that should be an option for people. So the research shows it has better retention for this specific group of people who were treatment refractory to oral options, but does have this higher risk of adverse events that don't necessarily exist for buprenorphine or methadone or Cadian. And so it's always kind of working with the client. What is really important is patient choice, which helps them to engage in the treatment and be successful with their outcomes. So it should be part of a continuum of care that's offered to people if they're injecting opioids, but it can be used in conjunction with oral options, including OAT. It can be used with safe supply. Lots of folks who go on iOAT eventually do transition to oral OAT options. And partly that's because iOAT is so high intensity. You have to go to the clinic multiple times a day. It's very hard to go back to work, to carry on with your life, to travel anywhere. And so lots of people do eventually transition to other options. What's important in the research is that that's patient-led. So stopping someone too soon isn't doing them any favors, kind of keeping the treatment open-ended and following them with their goals and building support around what that is what's best.
I was talking to Dr. Jankowski one time and I had asked him the question, like, what is the best OAT? And he said, well, we used to be told that we should kind of push people towards like Suboxone. And now it's more just like whatever the patient is going to have to take is the one that you're going to offer. So whatever, because the best one is the one that they're going to be compliant with or that they're going to be willing to take. So, and so we see those ones more often, but we haven't seen the iOAT in acute care. So is anybody prescribing that?
That's such a great question. So we did a couple of years ago in acute care when I was running that iOAT clinic in the community. We had patients come to RGH and actually they ended up in the ICU because of the post-dose monitoring requirements at that time, but only a few times. We do have clients in the community now again on iOAT in a different community program. And so we could be providing iOAT care here in hospital. I recently did some sessions with CNEs and CNLs around iOAT continuation to highlight the resources that we have in Island Health for that. And I can share that with you if you want.
Okay, so yeah, because I haven't seen that being prescribed much. And
Totally.
one patient that was a burn and was in, but I don't think it followed any like order set necessarily. It was on IV morphine for addictions, and they ended up transitioning to a PCA, and that was like covering the withdrawal piece, and then the ketamine for like the background pain piece.
Love
and I remember, like the nurses at the bedside so then procedurally we were like, okay, well, you know, we've got the withdrawal piece covered and we've got the background pain piece covered, but what are we going to do for procedural pain? And like some of the nurses were like, well, it's on this massive IV morphine dosing, and I was like, well, that's literally just to stop going from withdrawal. So we don't actually have a procedural like plan yet. But I don't think it was like true IO ordering.
Totally. Not all IV opioids are going to fall in this IO treatment umbrella. We're working on updating the clinical order set, and it will be for CPOE activation. We'll have an electronic IO order set, but not all IV opioids are going to fall within that order set and might look a little bit different. We tend to use the order set for patients that are formally on an IO program in the community, but
someone like that, you're right. It's not, we're not initiating items necessarily, we're just managing the withdrawal.
Yeah, and would still be using the same learnings in terms of high dose opioid administration, looking at your IV orders or the IV monograph and that for information. I would love to see an order set that has that is for non-IOT IV opioid administration for people with high opioid tolerance, like people with opioid use disorder. And I hope that's work that we're going to kind of move towards too. But we don't have it quite yet. I'll maybe end it for the folks online, but thank you so much for coming today if you're still with us. And yeah, thanks and take care.
Thank you so much. Thank you.